Okay, Suprita, over to you. Hi, Suprita. We can start. You're on mute. Am I audible? Yes, Suprita.
Yeah. So, am I audible?
Yes.
Yeah. Hi. Okay. So, hi everyone. Good evening. I welcome all of you for today's classroom session, which is on valvular heart disease. So today we have our speaker, Dr. Raghunandan, who's a consultant cardiologist in Bangalore for the past 15 years. He has an excellent academic background, securing 10th rank for the state in SLC, and he represented Karnataka in India Quiz 1994, Doordarshan. He has been awarded the best research paper during the state CSI conference. He recently received Sri Ramanuja Seva Sri Award from Sri Yadagiri Yatiraj Math, recognizing his service during the COVID pandemic. He has expertise and experience in independently handling cardiac emergencies, elective and emergency coronary angioplasty procedures, complex interventions, pacemaker device, and other cardiac intervention. I welcome you, sir, for today's session. Also, I would like to invite Dr. Sunita to start with the presentation. I also welcome Dr. Sarin, who's the chair, National Executive Team Spice Route, and Dr. Jyotika, who is here today. She is the secretary, Spice Route National Team. Also, Dr. R.K. Prasad, who is the president, Karnataka State Chapter AFPI. I welcome all the participants here. And I appreciate everybody's, in spite of the initial glitch of wrong meeting ID, it's good to see good number for the meeting. Sunita, over to you. You can start the presentation.
Hello. Hello.
Yes, we can hear you, Sunita.
Dr. Suprita, can you please share my presentation?
Good evening, everybody. Am I audible? Dr. Raghunandan here.
Yes, we can hear you, Dr. Raghunandan.
Okay.
Sunita, can you try sharing your screen? I've made it. You'll be able to. Yeah. Okay, it's visible.
Okay. Today's presentation is on valvular heart disease, and I'll start.
Please start, Sunita.
Yeah, ma'am, I think Dr. Sukrita can control my slides. Okay, so my patient, Mr. ABC, is a 44-year-old male. He's a bank employee by occupation and is a resident of Bangalore. He belongs to class 3, that is lower middle class scale of the modified Kupuswamy socioeconomic scale. His chief complaints were breathlessness on exertion since 10 years. He was admitted on the 1st and examined on the same day. He is a known case of hypothyroidism since 20 years on 125 mcg of thyronome. He is a known case of diffuse B-cell lymphoma since 10 years and has status post 6 cycles of chemotherapy and radiotherapy and is in remission. He is also a known case of obstructive sleep apnea on CPAP at night since 1 year. He presented to the OPD with complaints of breathlessness since 10 years, which started with the patient experiencing breathlessness while walking up the flight of stairs to his office, which was around 2 flights of stairs, class 2 NYHA, but he could continue to do so. It's only since 3 years that he experienced marked limitation of physical activity. He was unable to climb up the flight of stairs to his office, hence he also had to leave his job. Although he can carry out the rest of his ordinary activities of daily living well, he has no breathlessness at rest. So since 3 years, he has progressed to class 3 NYHA. On his routine follow-up for his existing comorbidities, 3 years back, he was told that he had a heart disease for which he had to be on regular follow-up. There was no mention of any heart surgeries at this stage. I would like to mention a significant past history here, since it helps in the interpretation. He had one episode of acute breathlessness for which he needed hospitalization, which was in 2012. He had fever with acute onset of breathlessness, left-sided chest pain, abdominal distension, and pedal edema. It was on this admission that he was diagnosed to have left-sided pleural effusion due to pulmonary tuberculosis, which is when he was diagnosed with diffuse B-cell lymphoma. It is only since this episode that he experiences breathlessness on exertion, and it has worsened since 3 years to NYHA class 3. After this admission, the patient continues to have breathlessness, which has progressed from NYHA class 2 to class 3 since 3 years. Patient does not recall any complaints of breathlessness, chest pain, syncope, or cough prior to this episode, that is prior to 10 years. As of today, there is no history suggestive of paroxysmal nocturnal dyspnea, orthopnea, syncope, or chest pain. No history suggestive of nocturia, no history of palpitations, no history of abdominal distension, pedal edema, yellowish discoloration of the eyes, or decreased urine output. There is no history of chronic cough, smoking, or any smoke exposure. No history suggestive of a congenital heart disease, no history of chest pain, and no history of repeated episodes of acute breathlessness at rest. Past history. In 2012, 10 years back, he had presented to the hospital with acute breathlessness, left-sided chest pain, fever. He was diagnosed to have left-sided pleural effusion with diffuse B-cell lymphoma in 2012, 10 years back. He has received 6 cycles of chemoradiation and is in remission. Also, 6 months of anti-tuberculosis treatment. Currently, there's no ongoing treatments for the above condition. He has hypothyroidism since 20 years and is on 125 mcg of thyronome. He's on regular follow-up and reports a normal TSH on the last follow-up. He has obstructive sleep apnea, is on CPAP at night since 1 year and comfortable. There's no history of hypertension, diabetes mellitus, dyslipidemia, COPD, or asthma. Personal history. His diet is mixed, bowel bladder is normal, sleep is normal, and he has no habits. His treatment history since the past 2 years is he is on atorvastatin and ecosprin at night, ramipril 2.5 mg OD, nebivolol 2.5 mg OD, spironolactone 5 mg OD, and eplerenone 25 mg OD. Family history. There's no history of cardiac disease, hypertension, diabetes mellitus in parents or the siblings. There's no history of sudden cardiac death in the family. So to summarize, my patient is a 44-year-old male. He's a known case of diffuse B-cell lymphoma, hypothyroidism, OSA with comorbidities, well controlled, presented with chronic history of breathlessness since 10 years, and one acute episode in the past with an identified precipitating factor. Okay. So, which the past episode is more suggestive that he had a cardiac failure secondary to pleural effusion. And on the pattern of his history, I feel it is more belonging to the cardiovascular system than the respiratory. I feel he has a chronic condition that has worsened with the existing comorbidities and the treatment.
Yeah, Dr. Sunita, that was a very detailed and exhaustive history that you presented. The one question before we go into the discussion, what do you think was the presenting history in this patient that brought him to the hospital of a symptom that has progressed over 10 years? What actually brought him to the hospital today?
So the breathlessness has brought him to the hospital.
No, the breathlessness has been there for a long time, isn't it? But
Yeah.
was it so severe that he had become orthopneic or he had developed other suggestive symptoms which would lead to some diagnosis for you to say probably there was something underlying which was worsening in the last few days for him to get hospitalized? Anything you found in the presenting history when you spoke to the patient?
No, sir. Actually, his complaints were that the breathlessness had worsened since 3 years.
Yes.
And it limited his physical activity, which was not the case before.
Okay, so for a history that was again 3 years back had worsened, to bring him to the hospital, there was an acute worsening in terms of having an orthopnea, having any fluid overload kind of a picture? Because you did mention that possibility of cardiac failure in your summary. Was there anything to tell you? Any specific thing that brought him to the hospital?
This current admission, no, sir. There wasn't any acute complaint that he had.
Even before we go to the diagnosis of what could be the system involved, I think we should analyze the symptom itself, given the long history of dyspnea that he's had, which has been progressive one. Second, he's had multiple issues which could point to different things. He's had obstructive sleep apnea. He's had a beta cell lymphoma for which he has undergone chemo and radiotherapy.
Yes.
Do you think any of this could be related to his progressive worsening of the symptom? Or in what way do you think that would contribute to the history of his presentation?
So once he's B-cell lymphoma, he has received chemotherapy and radiation therapy. So
Yes.
Definitely it contributes to both the lung and cardiac toxicity.
Absolutely. Yes.
Radiotherapies can both lead to pulmonary fibrosis. Also, the normal regimen that we use for NHL, doxorubicin is a cardiotoxic drug.
Yeah,
So,
probably one of the possibilities you could think of is a drug-induced cardiomyopathy, or probably radiation-related fibrosis, which could again lead to probably lung issues. Okay. And of course, you said something about having pleural effusion, which was thought to be tubercular, and he received anti-tubercular therapy, but that any parenchymal lung disease. Why I'm specifically mentioning all this is, see, though the focus is on looking at whether there's a possibility of a valvular heart disease, when you look at a patient from a point of view as an examiner, you should have a much more broader view of looking at all the symptoms before we come to a conclusion where we are trying to rule out all possibilities, because there's a long history of disease. He has lived with dyspnea for 10 years. It is not that he's acutely worsened. So the natural history of his symptom progression has been quite long. You yourself mentioned from NYHA class 2 to class 3, it's taken about 7 years. Then from class 3, it has probably been progressive now in the last few days, which probably has brought him to the hospital. If you look at it, how the progression of the symptoms are.
yes, sir.
And he's also a known hypothyroid. His age is somewhere in the 40s. So, considering all this, what are the possible diagnoses you can think of at the clinical history level itself? You can
Um,
mention both the systems. We know dyspnea is a symptom, both cardiovascular disease and respiratory disease. So we have to look at the various differentials which could be most appropriate for his kind of a background of history and his age group, because each symptom will have its own weightage at different age groups and different comorbidities.
yes, sir.
If you have to tell me one, two, three, four, what would those be?
Yes. Ma'am, can we have the next slide? So first things and the most common presentation that we see, I would say, is anemia. So anemia can also present with breathlessness of a long duration. Second, it could be a valvular heart disease that is presented after at this age with early symptoms of left ventricular failure. He could also have an adult presentation of a congenital heart disease, which is less likely in ASD because ASD normally presents with right ventricular failure symptoms. He could also have a cardiomyopathy, which is secondary to chemoradiation, or a fibrosis secondary to the chemoradiation or tuberculosis.
If I would ask you to probably again go back to your history and see if any of these one can go up, one can come down. See, we are not really looking at what is the final diagnosis here. We are only in the stage of analyzing the symptoms, analyzing the history to know what should be our 1, 2, 3, 4. See, anemia, you talk of chronic anemia, people who are chronic anemia of various causes of the various systemic diseases do not actually acutely present with dyspnea worsening unless it's an anemia of a recent cause. So to say anemia without having any evidence of any other things which is not presented in the history in terms of blood loss or in terms of having any past history of having received blood transfusions, I don't think we can really just think of anemia as the first cause. If you just look at the history itself, you would still want to first rule out possibility of probably a drug-induced cardiomyopathy, as you mentioned in your one of the differentials, or a pulmonary fibrosis secondary to the radiation, or an underlying parenchymal disease of the lung like tuberculosis, which are all, and he's also a known case of obstructive sleep apnea, mind you. So they have a very low respiratory reserve in these kind of patients. So for me, to put it as a valvular heart disease straight away would still not be first on my thoughts. So when you present the history to make it very unbiased, probably we should always think of all other possibilities before we label it as probably secondary to valvular heart disease. So adult congenital heart disease, again, ASD presenting as a dyspnea alone, and that too that long a history would usually be very unlikely. We know that these patients would probably present in their late or early 40s, but the natural progression will be such that the symptomatic stage will be much shorter than the asymptomatic stage. Because once they become symptomatic, it's a stage when they have developed pulmonary hypertension. Whether they Eisenmengerize or whether they're going to right heart failure is a much later stage. Symptoms start only when pulmonary hypertension has set in. Okay. And which valvular heart disease do you want to think of when you have such a long history of gradually progressive dyspnea as a symptom?
So involvement of the mitral valve or the aortic valve.
No, we always know those are the two valves that we always look at when we talk of valvular heart disease. But among the mitral, among the aortic, going by this history of the progression of symptoms for a long period of time, it would give you some clue.
So mitral.
Any thoughts? And are you looking at a stenotic lesion or a regurgitant lesion?
So stenotic lesions, okay, so mitral stenosis, they present, all mitral stenosis MRARs, they present with symptoms of left ventricular failure. It's only aortic
Not
stenosis.
always. Not always. See, we have had patients presenting first time during their pregnancy as a silent mitral stenosis. They can do their normal activities with mitral stenosis as long as their left atrial pressures are not increased. Only they can present when the left atrial pressures go up. So mitral stenosis presenting just as a progressive dyspnea over 10 years may not be of the first choice among the valvular lesions we think of. Yes, mitral regurgitation, I would say, but there would be associated symptoms like palpitation. Okay, patient would have more frequent progression and related to the regurgitation symptoms that worsen. And only other thing what I can think of probably is the longer period of patient having symptoms where they worsen more in the later stages, aortic valvular disease, either aortic stenosis or aortic regurgitation, which have a long asymptomatic or slowly progressive phase and then a quick deterioration. If you look at the heart failure or patient's natural history of heart disease. I hope you're understanding what I'm trying to say in terms of natural progression of symptoms. Okay.
Yes.
Yeah. So at this point of time, we would still want to think of probably a drug-induced cardiomyopathy or a pulmonary cause related to pulmonary fibrosis or a parenchymal disease or probably a valvular disease which has been progressive as the main possibilities. Of course, ruling out possibilities of anemia given the patient's socioeconomic status would still be on mind. But to consider the congenital heart disease as a presentation of progressive symptom worsening would still not be the first. Or if you're thinking of a valvular disease, I'd give you one more hint. Do you think non-rheumatic valvular disease of any kind could present this way?
Yes, sir. So if there is a bicuspid aortic valve.
Very good. So bicuspid aortic valves are known to present with aortic valve stenosis much earlier than degenerative and rheumatic causes of aortic valve disease. Their disease progression is definitely faster than tricuspid aortic valves and they manifest in terms of symptoms much earlier. So why we have to look at all these possibilities before we go into an examination is you should know what to look for in the examination to corroborate your findings in the symptom stage itself. Do you take any history of any other possibilities of dyspnea being a symptom of any systemic diseases?
So, sir, the patient didn't have any chronic cough, didn't have
Okay.
any smoking food, smoke exposure to improve chronic obstructive pulmonary diseases, giving
Okay.
the long list of his dyspnea.
Fine.
Mm,
Anything you want to add to the history?
yeah, so sometimes connective tissue disorders, they can
Very
have
good. So possibility of other systemic or connective tissue disorders presenting with lung involvement, presenting with cardiac involvement. See, at the history level in a 44-year-old, we are not looking at either a young patient with valvular disease or a childhood congenital disease. We are looking at a more broader view of a symptom of dyspnea here. So why do you think we can't even think of even ischemic heart disease presenting like this?
we can, because he also has comorbidities.
Yes, of course, he's not a diabetes, not hypertensive, but nothing prevents from him having an anginal equivalent as a dyspnea, which has been progressive over the years. He's also known hypothyroid, and hypothyroid patients are known to have dyslipidemia. So basically, we should probably looking at a wider picture of a patient with dyspnea in this case, rather than going little bias only towards a valvular disease.
Yes, sir. Yes, sir.
Okay. You can go ahead now.
Yes, sir. Ma'am. Okay. So general physical examination. The patient was examined in sitting and supine position. His BMI was 120, was 21 kg per meter square, and is overweight. He was conscious, cooperative, and oriented person. His temperature, he was afebrile. His pulse rate was 80 beats per minute. It was a slow rising pulse and a low volume pulse. It was regular in rhythm, equal on both sides. There was no radioradial or radiofemoral delay. Peripheral pulses were palpable and were of low volume. The blood pressure was 110 by 70 mmHg in the right upper limb, 108 by 64 in the left lower limb, and one left upper limb, 120 by 70 in the right lower limb, okay, which was normal. Blood pressure was taken sitting position. The respiratory rate was 16 cycles per minute. It was thoracoabdominal. There was no increased work of breathing. This is accurate or not. His saturation was 98% on room air. Jugular venous pressure was 5 centimeters above the sternal angle, and it was normal. There was only a transient rise on hepatojugular reflex. Pallor was present, lower palpebral conjunctiva. Icterus was absent, cyanosis was absent, clubbing was absent. There was platinentia, bilateral nails. Edema, there was bilateral pitting edema after the anesthesia. There was no cutaneous signs of coronary artery disease, no cutaneous signs of atherosclerosis. At the end of general physical examination, the positive findings were there was a low volume pulse, there was pedal edema, and pallor.
Yeah, we'll stop here. So you had some symptom related differential diagnosis for your case, and now you're done the general examination. So you already mentioned about the low volume pulse and the low normal blood pressure reading and some evidence of a pedal edema with presence of pallor. So among those, what do you think now you'd be more favoring in terms of your diagnosis by the general examination itself? Because before you go into systemic examination, you should have an idea of what to look for further.
So the general physical examinations point move towards the cardiovascular system, then the pulmonary, then the respiratory system.
Very good. Okay. So what kind of cardiovascular disease do you think you are looking at? See, you didn't mention about possibility of a heart failure presentation in this patient as a acute worsening presentation right now, isn't it? So what evidence is there to support it or not support it in what way does your general examination help you to look at that point?
So he had bilateral pitting edema, sir, which is seen in uh, right-sided heart failure. He also has a low volume pulse.
But
So
what is evident that is not there when you want to talk of clinical overt heart failure?
there should have been a bounding pulse.
No. When you're talking of a patient, look at signs of heart failure. Yes, one peripheral edema. What else? You did mention about something.
He's not feeling.
What do you think the JVP was? No.
Sorry, the baby should have been raised.
Yeah. So JVP being normal in a patient with overt heart failure of any cause, or especially if you're thinking of a valvular heart disease, okay, is definitely one point that tells you, he's probably not in overt failure at this present time, isn't it?
Yes. Yes.
Yeah. And then what does a low volume pulse indicate towards which valve involvement could be there?
Aortic.
So you have a pulse which was weak, slow rising, low volume.
Yes.
No, just possibilities I'm saying.
Yes, sir.
Are
It
you
was
looking at a stenotic lesion or are you looking at a regurgent lesion?
no. Given the character of the pulse, it should be a stenotic lesion.
Yes. Possibly which valve involvement?
So aortic stenosis.
Okay. So what does the blood pressure tell you?
So the blood pressure was 110/70. The pulse pressure is normal. Actually, the pulse pressure should have been low.
Right. So it's still a no normal range of blood pressure. You don't have radiofemoral delay or radial delay. You don't have a wide pulse pressure. You don't have any variation in the pulses from the lower limb to the upper limb. So probably, and you don't have any irregular pulses to suggest any probably an atrial arrhythmia kind of thing. So a lot of things are more towards a aortic stenosis, which you probably should be thinking of if you think of a valvular possibility in this patient. When you just look at some of the clinical general signs itself, and probably patient is not in overt failure.
Yes.
Okay, we can go further.
Systemic examination, the cardiovascular system. On inspection, first the neck inspection, the carotid pulsation was seen and normal. There was no carotid bruit, no abnormal pulsations in the neck region, no midline swelling was seen. Trachea appeared central and trail sign was absent.
Okay.
Chest on inspection, there was no deformity in the spine and chest wall. There was bulging of the precordium. Apical impulse could not be visualized. Skin over the chest wall was normal and no surgical scars were present. No abnormal pulsations were seen, especially in the epigastric and parasternal region. On percussion, the cardiac dullness is normal. Upper heart border was corresponding to the left third intercostal space, which had a dull note. The left second intercostal space is resonant. The right heart border is substernal. Left heart border corresponds to the apex beat along the mid-clavicular line in the fifth intercostal space. And the liver dullness is at the right fifth intercostal space. On palpation, the apex beat was palpated at the fifth intercostal space, 1 centimeter lateral to the mid-clavicular line. It was shifted laterally, outwards but not downwards. It was well localized to the fifth intercostal space. It was sustained and heaving in character, suggestive of left ventricular hypertrophy. There was no palpable heart sounds in the mitral, tricuspid, pulmonary, or aortic area. Trachea was central on palpation. Auscultation in the aortic area, the S2 was soft. Presence of ejection systolic murmur, which was grade 3. It was loud, but with the absence of thrill. It was high pitched and best heard with the diaphragm in the aortic area, with the patient sitting in sitting position and an expiration. It was radiating to the carotid and the other areas of mitral, tricuspid, and pulmonary. In the pulmonary area, S2 was single. The radiating ejection systolic murmur was present. There was no evidence of pulmonary arterial hypertension. In the tricuspid area, S1 was normal along with the radiating ASM murmur. In the mitral area, S1 was normal and the radiating ASM murmur was heard. At the end of cardiovascular system, our positive findings were low volume pulses, a bulging precordium, heaving and sustained apical impulse shifted laterally, ejection systolic murmur, best heard in the aortic area radiating to the carotid, and a single S2 in the pulmonary area.
Before we go into the discussion of the cardiovascular system examination, one thing you need to be careful when you commit on the apical impulse. You said the patient had a BMI of 21, and then you said the apical impulse was not visible, and then you mentioned that he had a heaving sustained apical impulse. So do you think all three correlate? In somebody who has a thin chest wall with a heaving apical impulse, you would definitely be able to see it
Yes.
in a male patient. So I think when you do mention if the apical impulse has to be heaving, if there is a sustained apical impulse, like you said, probably due to left ventricular hypertrophy. So if you're thinking of a valvular disease, so probably you have to be careful in saying the apical impulse is not visible, or probably mention that it was not very evident rather than committing it that it was not seen, probably because of obesity. So there might be slightly contradicting to each of these. Okay. And you did mention that the murmur was radiating to the other areas. What do you call that? See, you're talking of a murmur which is best heard in the aortic area. And when you're talking about ejection systolic murmur, you probably are thinking of what?
Aortic stenosis.
Yes. So an aortic stenosis murmur, which probably is heard also in the other areas, it's called the Gallaverdin effect. And you have to describe the murmur a little more for us to probably get to know what is the severity of the aortic stenosis. What is the duration of the murmur? What is the nature of the murmur that you're hearing? See, a typical aortic stenosis murmur will be what? A crescendo, decrescendo kind of a murmur. And longer the duration of murmur, more severe the aortic stenosis. And the peaking of the murmur, later the peaking, more the severity. I hope you're getting the clinical aspects of how to describe a murmur, because our clinical examination should, from the general to the systemic, lead us more towards the diagnosis which we thought initially was to be considered in the history level, and then at the general examination level coming on to the systemic examination. What else would you look for in a patient if you're thinking of aortic stenosis as one of the possibilities of your diagnosis here, which you didn't mention in your auscultation? If you had to go back and look for in this patient. I'll give you one more clue, because that was one of the etiology also we did think about when we discussed the natural history of the valvular lesions.
Bicuspid valve. So.
Yes, very good. What would you look for clinically when you examine? The presence of a click In a bicuspid aortic valve, you probably sometimes can hear a systolic click in the aortic area, which will give you some clue, if it is there, that this could be a congenital bicuspid aortic valve stenosis rather than an acquired rheumatic or a degenerative aortic valve stenosis. Okay.
Yes, sir. Yes, sir.
Yes. So these are the additional things you need to look for when you are actually examining a cardiovascular system, especially in a valvular disease, where each of these will have some value to your diagnosis.
Yes, sir.
Yeah. Anything else you want to add in the systemic examination? The other systems, I think you are just trying to.
Yes. So,
Sorry. Yeah, you can go ahead.
yes. So, respiratory on auscultation, there were localized left mammary crepitations, which was coarse, and gastrointestinal system, there was hepatomegaly of 3 centimeters below the RCM, right costal nerve. It was non-tender, only transient hepatojugular reflex, and CNS there was no focal deficits. So another system, one was the crepitations in the left mammary area, and the other was hepatomegaly. So at the end, what provision diagnosis I would give based on history and physical examination would be that it is a valvular heart disease, mainly involving the aortic valve, stenotic in nature. Etiology, I would like to revise it and say it would be a congenital bicuspid aortic valve or acquired rheumatic, but rheumatic it's too early for presentation. It is the in sinus rhythm, not in overt failure. There's no evidence of infective endocarditis, acute rheumatic fever, or pulmonary arterial hypertension. No precipitating factors currently. Uh, Also, the crepitation in the left lung can be because of post pulmonary tuberculosis bronchiectasis, and because of the platinum and pallor, he can have anemia, but this is all to confirm through investigation.
Okay. So we'll just go back to the diagnosis. So each one we look at it. So you said valvular heart disease, probably involving the aortic valve, more likely to be a stenosis. Okay. So what else do you think could be the possibility other than just aortic valve stenosis? Still just going by what we saw. Any other possibility?
Calcification of the bicuspid aortic valves.
No, no, I'm not talking the etiology here.
Okay.
Apart from valvular heart disease like an aortic valve stenosis, which could have all the features clinically that you mentioned,
Yes.
any other possibility where the presentation would be similar?
So cardiac cause only.
Yes, could it be anything else just as a differential for you to look at as one of the possibilities I'm saying? Could this be a hypertrophic obstructive cardiomyopathy presenting with an ejection systolic murmur with patient having a heaving apex? What would be different there if you have to look at the general examination? Would the blood pressure response would be the same as aortic valve disease in a HOCM?
So I think there would be increased blood pressures in HOCM.
Blood pressure response would be definitely higher, yes. And would the apex be the same?
No, the apex there would be cardiomegaly, left ventricular dilation. So the
You
apex would
will
be
get ventricular dilatation in a hypertrophic cardiomyopathy in the early stage if the patient is not in failure. Probably you would have a more heaving apex, but you may not have a enlarged left ventricular dimension as much as you see with the aortic valve stenosis. So you would not have a laterally shifted apical impulse, though it would still be healing. Okay. And coming to the etiology, what the evidence we have in the history or in the systemic examination to tell us it's possibly rheumatic? Is there anything?
There is no past history of rheumatic fever
So,
or in
yeah, in Indian population, you might not still get a clear history of a rheumatic disease in childhood, given the kind of upbringing most of the social economic groups the people would have. They would still be exposed to the streptococcal infection. Yes, but you haven't still been able to say whether it could still be a congenital bicuspid aortic valve. So, in terms of etiology, you could still not be able to say whether it's either bicuspid aortic valve or a acquired rheumatic valve disease. Okay, that is one. And of course, there was some pedal edema, but there are no other signs of failure. Rather than putting a pulmonary diagnosis separately with this, why can't the crepitations, what you mentioned, be part of some early failure in this patient? When you have a valvular heart disease, patient progressing over so many years, you can
So
still.
the crepitations are very localized to the left mammary area. In left ventricular failure, normally they would be basal, bilateral, fine crepitations.
Accepted, but the general dictum is to make sure most of the findings, if possible, can be explained with one diagnosis rather than multiple diagnoses. Of course, anemia is something which can precipitate a worsening of any of these systemic diseases. So, presence of pallor alone with some general signs of anemia need not be, a factor that could be the reason for his dyspnea. It can only worsen it. Okay. So the pulmonary bronchiectasis would still probably lower on my list. We'll just look at valvular heart disease alone causing all the symptoms that he has. And being the disease you're thinking of, which is an aortic valve disease, where the natural progression of the disease has to be long. We are thinking of an aortic valve stenosis. We are still not sure whether it's a congenital bicuspid valve because we don't have any clinical evidence for that to support that, or we don't know whether it's a rheumatic acquired valve because in India, rheumatic valvular disease is much more prevalent than congenital one. Okay, so we only can say at this point of time it's an aortic valvular disease, probably involving the aortic valve, which is acquired and more of a stenotic in nature. Patient not being in failure, patient not having any arrhythmia, patient being in sinus rhythm, no evidence of an endocarditis. Okay, so I think that is the conclusion we can arrive at with the clinical finding that you have mentioned.
Yes, sir.
Okay.
My plan would be first line investigations basic. So to know his HB, whether he actually has anemia, his total counts, and creatinine. Chest X-ray to look for cardiomegaly, lung fields, any calcification of the aortic valve. ECG to look for left ventricular hypertrophy. And a 2D echo to confirm if he has the valvular heart disease.
So why would want to do each of these investigation? Hemoglobin will tell us about anemia, yes. Okay. You need probably a peripheral smear to tell you the cause for anemia. Okay.
Yes.
Creatinine, again, if you're looking at other possibilities of patient having pedal edema secondary to other diseases, where probably you would not want to consider them as a first possibility, but still, as your general evaluation, you want to be making sure we look at all that. One other reason being probably patient's treatment history you gave of patient being on ACE inhibitors and patient being on spironolactone. So looking at the renal parameters makes sense. But when you talk of the others, before you do a chest X-ray, what do you want to look for in this patient on the chest X-ray? Going with all that history and examination findings that you had.
So
What
first,
do you want to see on the chest X-ray?
yeah, to look at what is the cardiac size, if there is any cardiomegaly,
Yes.
The cardiothoracic ratio on the X-ray.
Yes.
Second, since there were crepitations to look if there is any consolidation or evidence of
Consolidation is more acute, isn't it? You would want to look at what? Evidence of what?
pulmonary edema. So, battering
Okay.
appearance, if there are B lines.
You mentioned something of bronchiectasis, isn't it?
Yes.
In your final diagnosis. So,
Yeah. Uh, chest X-ray findings of bronchiectasis would. I'm not sure about.
we probably want to look at both the lung fields to look at what is the lung involvement here, given his prior history of having had, pulmonary cox, he's had chemo radiation, and is probably as a post-tubercular bronchitis being one of the possibilities, yes, and possibility of pulmonary edema there, okay. And before you go to the echo, ECG, what do you want to look for in the ECG?
Evidence of left ventricular hypertrophy. So look at the voltages in the lateral leads,
Yes.
the R wave. Also to
Okay.
look if there is any left excess
You
deviation.
have the X-ray and ECG here?
So I'm sorry, I haven't put it on the slide, sir.
What was there in the X-ray?
So the X-ray was actually the lung fields were clear. There wasn't any evidence like the cardiothoracic ratio was normal, no calcification on the aortic valve.
Okay. So when you're talking of an aortic valve disease and X-ray, you say the cardiothoracic ratio is normal. What does it tell you more about?
Um, it's a early.
Okay. It tells you probably whatever is causing is more of a pressure overload rather than a volume overload.
Yeah.
So you are not having any enlargement of any of the cardiac chambers to increase the cardiac silhouette to make the cardiomegaly being evident, isn't it?
Yes.
So which of the ones, again, if you look at the chest X-ray itself, where you find probably a nearly normal heart size among those lesions, what would you want to look at when you have a patient with mitral stenosis?
So in
So
mitral
these are all just for discussion so that we have a more of a learning process. I'm not just trying to evaluate just this case. Because when you look at an X-ray, you should be able to find something which will help you make a diagnosis.
so in mitral stenosis, there is left atrial enlargement. There's
Very good.
there's the straightening of the right heart border.
Clear. Yes.
Sometimes there's the double heart border.
So the mitralization, you'll probably have to look at that. And what evidence you will have on the lungs to look at? You'll have to probably look at the pulmonary venous congestion features, which again would indicate severity of the mitral stenosis. Yes. So left atrial or biatrial enlargement. Okay. And what about mitral regurgitation? Chronic
So,
mitral regurgitation, you may have a LV type of a cardiomegaly. Okay.
yes.
And if you're thinking of a combined aortic lesion with aortic stenosis with aortic regurgitation, probably one of the largest hearts you would get, huge cardiomegaly would be there because it's both a volume and a pressure overload on the left ventricle. Whereas in an aortic stenosis, till a very late stage, the NV volume enlargement will not be so obvious as the pressure effect on the left ventricle, which probably causes more hypertrophy of the cardiac left ventricular muscle than dilatation of the chamber.
Yes.
Okay. Yeah. So what did you find on the ECG?
So his ECG had a left excess deviation. It was in sinus rhythm. It also showed an incomplete RBB. And ECG wise, there was no evidence of LVH.
Just a small suggestion. Next time when such cases are discussed for the benefit of the audience, it's better to put up those chest X-ray or ECGs for people to have a better understanding.
Sure, sir. Sorry.
And what about the 2D echo?
So 2D echo showed a ejection fraction of 40%, calcified outer valve with severe aortic stenosis, concentric LVH. There was no regional wall motion abnormalities. He also had a mild AR, mild MR, and mild TR with mild pulmonary arterial hypertension. He had a normal LV systolic function and right ventricular systolic function. And there was grade 1 LV diastolic dysfunction.
How was the valve description on the echo? What about the number of leaflets? See, we have been looking at the possible structural etiological cause for the aortic stenosis, isn't it? So
Yes.
your echo is the one that clinches the diagnosis finally.
Yes.
Was there any aortic valve leaflet thickening? Was it a bicuspid aortic valve? Was it a tricuspid aortic valve? Whether it was more of an annular calcification? Anything was mentioned in the echocardiography that you finally could
No,
get?
sir. Actually, no. The patient had not got the formal report of the echo. This is what was documented.
Okay. So we are looking at a case of a severe aortic, calcific aortic stenosis, possibly of a rheumatic etiology, because they're not mentioned whether it's a bicuspid or a tricuspid aortic valve, with evidence of pressure overload in terms of concentric left ventricular hypertrophy, but no ischemic etiology of wall motion abnormality of any kind, and no other significant valvular lesions. But patient has an ejection fraction of 40%. What does that tell you?
Failing left ventricle.
So left ventricular dysfunction is evident with the ejection fraction 40%, isn't it?
Yes.
So there is one entity of aortic stenosis which possibly can fit into this. What is that?
Entity of aortic stenosis. Mm. Mm.
Okay, or I'll put it this way. So do you think in the natural history of aortic stenosis, left ventricular dysfunction happens early?
Actually, in aortic stenosis, the patients are asymptomatic for very long. Once
Yes,
symptomatic, they rapidly worsen.
correct. So what stage do you think your patient is right now?
The later,
So which are the three cardinal clinical presentations of a symptomatic aortic valve stenosis?
so they'll have angina, they'll have
Yes, syncope and heart failure, isn't it? So you have three clinical presentations which are normally described in aortic valve stenosis, right? So you are talking of a patient who has had progressive dyspnea, which could be an anginal equivalent over a period of time. Yes, the last 3 years probably has been having angina. And do you think patient has heart failure right now, going by what all you have seen in terms of his uh,
not overt heart failure, but
okay.
early signs.
Okay. So one other thing what I wanted to just you to know is there's something called an entity called a low flow, low gradient aortic valve stenosis. I don't think you would have come across that as a clinical entity. So one of the things you need to see what kind of burden on the left ventricular myocardium that aortic stenosis have.
Pressure overload. So
In the initial stages, there will be a pressure overload. Okay. So what will happen later is a pressure come volume overload. Okay. So we know cardiac muscle has both a preload and a afterload effect, isn't it?
Yes.
So when it comes to mitral regurgitation, it's more of a preload related thing. So those patients with significant preload, when they present with left ventricular dysfunction, that means the disease has already progressed to a stage where even your mitral valve replacement will not make the left ventricle normal in terms of its function. Whereas in patients with aortic valve disease like aortic stenosis, even if the preoperative ejection fraction is 40%, there is a good likelihood that the cardiac function, left ventricular muscle function would improve post surgery. Okay, so this is what we need to understand when we look at aortic valve stenosis in terms of the further management of the patient.
Yes.
Okay, was there any mention about the gradient across the aortic valve?
No, sir. Actually, this is what was documented. I will go back and
Yeah, probably you can just go back to understand for yourself to see what was the gradient. So with the ejection fraction being low, what probably would be the reason for the EF going down here? Because you don't have any evidence of other reasons for myocardial damage, like an ischemic heart disease, because there's no wall motion, there's no significant dilatation of the left ventricle, isn't it?
yes,
Yes. And what kind of a cardiac output would be there in a severe aortic stenosis?
decreased cardiac output.
A fixed low cardiac output state, isn't it? So that was one of the reasons why patients do develop syncope in one of the natural history of these diseases. So probably this patient would soon, if left alone, would develop probably syncope and go into overt heart failure. And then even the aortic valve replacement would not give him the benefit if he undergoes a aortic valve replacement surgery.
Yes.
At this stage, can you take some questions from the audience to the presenter? How does it work? Dr. Jyotika?
Yes, if anyone wants to ask questions, they can put it up in the chat. Of course,
Okay.
through the discussion, there were a few answers and comments that were there.
Yeah, I did see them. Somebody did mention
Yeah.
about the JVP, which she had not
JVP.
specifically spoken about, and then the Gallaudet phenomenon. That was very nice to see people getting involved in the discussion. Yes, and somebody did note in the negative history, she said no history of congenital heart disease and comes
Yes.
the differential diagnosis. Yeah,
Yes.
because I'm sure you can't rule out everything in the history. You need to keep all possibilities open. Never go with a biased kind of a focus kind of a approach, because you have mentioned it's a valvular heart disease case, but when you look at a patient doesn't come telling you his diagnosis. You have to reach the diagnosis.
Yes, sir.
We also have a few MBBS students who have joined. So if anyone
Oh,
wants to ask any question or say something, you can unmute. And the session will also be available on YouTube. We'll be sharing the link. So
yeah, I don't want to
uh,
go too much into the discussion of the management of this patient, because
yes,
a valve disease of the kind of one we have discussed, like an aortic stenosis, is a mechanical problem. So it needs to be dealt mechanically by the replacement of the valve. How you do it depends on the patient's clinical status, whether you go for a accepted surgical aortic valve replacement or the more recent transcatheter aortic valve replacement, or TAVI as we call it. So that probably would be a next level of discussion. Whereas for us, the clinical understanding and approach to the case is more important here.
yes, that's true. That's true. Management, of course, is a completely different discussion. So
The next
if
time
you want,
around, for anybody who presents, probably we should have the actual images of the X-ray or the ECG and the echo available, so that it helps
Yes,
in better understanding for the audience, so that they get to know more clear picture of the case that is being discussed.
true, true. Usually we do share.
That's a suggestion.
Copy was missed
Yeah.
in this. No problem. So,
Well done, Dr. Sunita. I think you can just go back and see your case again and see what better understanding you can get on dealing with the patient with an aortic valve stenosis.
yes,
Yes.
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 Okay, if there are no more comments, Dr. Suprita, maybe we can wrap up.
Yeah, that was a really good presentation, Dr. Sunita. And also, I thank Dr. Raghunandan for taking it step by step and letting everybody know the importance of each step and how we can get to the narrowing down to the diagnosis, differential diagnosis and getting to the diagnosis.
Yeah. Thank you very much for the opportunity. It's a learning process for everybody. Even we
Yes,
learn by
and
teaching. So
yeah, it was very well and nicely explained about when you're mentioning few points as as one of your examination findings. We have to be
right.
really careful about what we are mentioning, whether it is correlating or not correlating.
Absolutely.
Even the
Absolutely.
simplest, the BMI and
Right.
the heaving
Typical
pulse
Very
and
stuff.
all. Yeah. So
thank you. Thank
those
you for
things
the
are very
opportunity.
important for all the PGs and the UGs who are present here. I hope this session was helpful for everybody present here. Thank you so
Yeah,
much,
it's a
so much,
great
Suprita.
initiative. I think you should take it forward because clinical medicine is what we all need to probably pursue before we all become investigation oriented.
Yes, yes,
Uh,
true.
Thank you, ma'am. Thank you,
Yeah,
and good
thank you,
night to
Thanks,
thank
all.
you,
Dr. Raghunandan.
thank you, everyone.
Thank you, everyone. Good night.
Good night.